So then the next thing that really has changed how we initially approach patients with mantle cell are these drugs called BTK inhibitors. These are oral drugs that affect what we call pathways in the tumor cell. So in those mantle cells, there are signals telling the cell to divide and grow and replicate and accumulate. And these drugs block those signals in a pathway called BTK. And Bruton's tyrosine kinase is what it stands for. And these oral drugs have really changed the way we treat the disease. And initially, they were tested in patients who had had prior treatment, and the majority of patients had significant improvement in their disease. The first drug is a drug called ibrutinib, which is very effective but has more toxicity. You can have irregular heartbeat called atrial fibrillation or risk of bleeding. And that really led to the development of acalabrutinib and zanubrutinib. And in the US, at least, we're using these two drugs predominantly in patients with mantle cell. And this drug is no longer FDA approved for mantle cell given the side effect profile. So this study was published last year from our colleagues in Germany, and they also asked the question, do we really need the stem cell transplant? And what if we add these new drugs that work so well in the disease when it's come back after initial treatment, and we compare outcomes by incorporating them with the initial treatment. So this is a bit complicated here, but basically what happened was the patients who were eligible to have a transplant and get aggressive chemo with a drug called cytarabine were randomly assigned. So 1/3 went to this arm, 1/3 to this arm, 1/3 to this arm. This arm was standard treatment: chemotherapy, stem cell transplant, maintenance rituximab. This arm said, well, what if we add this BTK inhibitor, ibrutinib, to the initial treatment and then as part of the maintenance? And then the last arm said, well, what if we add the ibrutinib, but we take out the stem cell transplant? This you can see in the box down here. About half of the patients got rituximab maintenance. While this study was ongoing, we learned that giving maintenance rituximab yielded very good outcomes and kept more patients in remission than giving no maintenance. So the standard of care changed in the middle of this study. So what did we learn from this study? We learned that if you added ibrutinib to a stem cell transplant, it was better than doing the stem cell transplant alone. And what that arm that had ibrutinib alone was not inferior to doing a stem cell transplant. So here you could replace the transplant with the ibrutinib. And if you gave ibrutinib and stem cell transplant, that didn't seem to be any better than just adding ibrutinib. So this was yet another study that really showed us that probably the days of using high-dose chemotherapy are behind us. So what about what kind of treatment should we use before the stem cell transplant? And this is another study from the US that was presented at our hematology meetings this year, testing a number of different options. So again, this was what we call a randomized study. So patients were evenly distributed between these three arms. Patients either got chemo with bendamustine, rituximab, cytarabine, a very standard chemotherapy regimen, or they got that regimen with the addition of acalabrutinib, another one of these BTK inhibitors, or we just gave bendamustine plus rituximab and the acalabrutinib. So these were younger patients who could tolerate aggressive chemotherapy. And the thought was, well, if we add acalabrutinib, we can improve the number of patients who are in complete remission before considering a stem cell transplant. So this was sort of designed to be a partner study with that stem cell transplant study. And what we learned from this study was if you try to add acalabrutinib to high-dose cytarabine, it's too toxic. So that arm was felt to be not a good option. And the way the study was designed was that adding acalabrutinib to bendamustine plus rituximab, they were looking for that to be superior to the other arms and to be the best initial therapy. And it wasn't superior, it looked very similar. So this study is actually quite controversial in the way it's been interpreted. Some people say, well, acalabrutinib plus bendamustine and rituximab is just as good as the other arms. We should be using that. It's less toxic than incorporating cytarabine. But I think others of us have sort of interpreted this a little bit differently and think that, well, bendamustine, Rituxan, cytarabine is a very good initial treatment, and we should maybe save that acalabrutinib for down the line because the BR plus acalabrutinib wasn't superior. So more to come on this. It's still something that is being debated within the field. So in summary, for patients who are younger and can tolerate aggressive treatment, the standard treatments include bendamustine and rituximab plus cytarabine, or sometimes other chemotherapy like R-CHOP plus Rituxan cytarabine, or bendamustine plus Rituxan alone, with or without acalabrutinib, no stem cell transplant, and then maintenance rituximab with or without acalabrutinib. And I will mention, in that study that I showed you where we concluded we don't really need the stem cell transplant in people who don't have any evidence of disease at the end of initial treatment. We aren't really looking to assess that at the end of initial treatment in patients outside of the trial because the vast majority of patients are negative, and we don't know for sure that stem cell transplant is better if you have minimal residual disease because that arm was not randomized or compared to an arm without stem cell transplant.